topic of my talk is the perioperative assessment of the right ventricular function. So I will start my talk by asking you a question. What is the most underreported structure on adult echocardiography report? Is it RV? I knew because this talk is about the RV, so maybe, but it's very close. So, but sir, aorta and the pulmonary valve. So this is the answer basically because in Pakistan, most of the reports they don't mention about this thing. So let's so why but RV is very close to that, but RV as far as the perioperative echo is concerned is very, very important. There is a meta-analysis. I don't know how to use this, and I can't see that. Which was done in 2019, and that shows that the RV subclinical and subclinical dysfunction was associated with high postoperative mortality rates. So as far as the perioperative RV function is concerned, it is very, very important. So, RV comes first from wherever you start. Whether you are adult echocardiographer, you start from the parasternal long axis, you are doing, perioperative echo and transesophageal, mid-esophageal four-chamber view. If you are, pediatric cardiologist, you are starting from the subcostal view. RV is going to be the first thing you will be seeing. So, coming, how to assess the right ventricular function. So, in right ventricular function, we need to ask 8 key questions from ourselves, starting from RV is, is the RV dilated? Is it active or hypokinetic? Then we, systolic function, RV hypertrophy, left heart disease, any evidence of shunt or, tricuspid or pulmonary agitation, or, and last but not the least, the assessment of the pulmonary pressure. So starting from the, is the RV dilated? So most of the time we go for a visual assessment. If the LV size is normal and RV is larger than the LV, so we say it's severely dilated. So, but then we need, if it is dilated, then we need to measure, give it number to that. So for different, on different views we do that, and they are the views where we are usually measuring the RV and at different levels. But most reproducible is this one. This basal diameter. This is the most reproducible feature. But whenever it is dilated, we need to do the measurement at 3 levels. This is recommended in the guidelines, and it should be at end diastole, and RVID1 is at the basal 1/3 level, and then RVID2 at the level of the papillary muscles, and then the longitudinal diameter from the this is the annular plane of the tricuspid valve to the apex. So these are the normal values, and here I would like that you should be remembering this number, the 30, and then you should be remembering the RVID1. So these are the numbers, but there is a big difference here. The 2015 guidelines, their numbers, and the recent the normal reference range in echocardiography study, which is a large study done in Europe in 22 centers, and 1 American center is there. But there are difference of numbers. Like yesterday we were talking about the normal reference ranges of our own population. So there is a difference in that as well. So next question is if it is dilated, is it hypokinetic or is it active? So which one is hypokinetic? Which one is active? Yes. And if we see this type of picture in theater, we think we are doomed. So coming to the, when the RV is, active, dilated and active, there is, active RV left to right shunting should be excluded, especially ASD. There may be severe tricuspid regurgitation or pulmonary regurgitation. Then, if there is hypokinetic RV, then we always look for the RV pressure overload, especially acute or chronic pulmonary embolism, congenital heart disease, ARDS, especially in the perioperative periods. Severe left-sided heart disease is important in perioperative period. RV infarction, RV cardiomyopathy, end-stage pulmonary stenosis or regurgitation or tricuspid regurgitation, post-cardiac surgery, and post-thoracic surgery as well. So constrictive pericarditis and post-pericardectomy these very sick patients, they usually die of RV failure on third or fourth postoperative day. So now we have discussed that hypokinesis. Now we want to measure how much hypokinesis is there. So this is measured by the right ventricular function, and we all know that RV function is systolic and the diastolic. So this is not, the function of the RV is not measured easily. It has got a complex structure. It has got the inlet, and then there is an outlet, and then there is a body. So it's not that easy to measure the function of the right ventricle. For the longitudinal, we use the TAPC and the tissue Doppler, and then for the global function, we RV index and the RV ventricular, 2D fraction area change, and 3D ejection fraction, and RV free wall strain as well. So let's discuss them one by one. So I will not be going in detail. TAPC is, we know that is angle dependent, and we need to remember a number of 17 here. This is the normal number. If it is below 17, we are definitely in a fix. So RV free wall S prime is quite sensitive and specific for the RV function, and is done on the TDI. Yesterday we were discussing it, so I will not be going in detail. We need to remember the number of the 9.5 here. It's difficult to control this, red pointer. So RV S prime is, if it is more than 9.5, it is normal. If it is less, then definitely the RV function is down. Coming to the RV index of myocardial performance, the TI index, it looks difficult to do it, but it's not. I tell you, once you are doing it, it's not that difficult, especially if you're doing it on the tissue Doppler imaging. On pulse wave, it's definitely difficult because there is heart rate variation and all that. But on TDI, you can do it easily. So we all know about the formula A minus B and divided by the B is there, and the ejection time is there. I don't know how to control it. But A to E distance, and then this ejection time. So this is you need to measure it, and the software will do the next thing. But the thing is that if it is more than 0.54 on the tissue Doppler, there severe RV dysfunction, and if it is more than 0.64, there is it's associated with worse prognosis in pulmonary hypertension cases. Coming to the RV fraction area change, we all know that, and how to do it. The number is, if it is RV fraction area change more than 30% in males and more than 35% in females, is considered normal. Coming to the newer, things, the 3D RV function assessment, if the RV function is enlarged and visually impaired, the measurement of the RV volumes on 3D is recommended, and the normal value is 45%. Here, I will draw your attention towards the volumes 44 and 36. They are index numbers, basically. We need to memorize them. We have talked a lot about the RV global strain and RV free wall strain, and I will not be going in detail of that, and but only I want to show one thing, that if you look at the here, the TAPC is normal, but the free wall strain of the RV and the global longitudinal strain is low. So that means it's showing the subclinical sort of RV dysfunction, but it is there. So here the normal values, as Sir Imran was discussing earlier today. So we have already discussed these. The RV longitudinal strain is, the normal value is here, but more sensitive is RV free wall longitudinal strain. The number is 28.7 plus minus 4.1. So coming to the right ventricular diastolic dysfunction, is pretty similar to do the right ventricular diastolic dysfunction as we do on the left ventricular side. Yesterday we had a very good talk on that by Professor Dr. Shabazz Sarwar, and I will not go in detail, just a few points. If it is 0.2 to 2.1 EA ratio, it is normal. If it is less than 0.8, if it is more than 2.1, it is abnormal. And the other thing is, the difference is the RVE E prime ratio. If it is more than 6, it is abnormal. If it is less than 6, it is abnormal. So when we have assessed the systolic and diastolic function, now we want to narrow down our differential diagnosis, we go for the hypertrophy. It is done at the end diastole, free wall thickness more than 5 millimeter, at the tips of the tricuspid leaflets at end diastole is done. Do not include trabeculations and papillary muscles. So if it is more than 5 millimeters, it is hypertrophy, and it shows, the pressure overload. So, is there any left-sided heart disease? Majority of the left-sided heart disease, they will definitely affect the right side as well. So, if there is severe mitral stenosis, it's gonna affect the RV function and RV size. Yesterday, we had a very good case of that with anomalous pulmonary venous return as well. So, MR will again gonna affect the RV size and function. End stage aortic stenosis, again, it's going to affect the right RV size and function. And in perioperative period, post cardiopulmonary bypass, RV dysfunction is due to poor myocardial protection and incomplete revascularization. So these are the two things. If we have these RV dysfunction in the post-operative period, we think of that. And naturally, if there is left heart disease, we can have that as well. So if the RV is active and dilated, we need to rule out the shunt above the right ventricle. This is missed quite often, and we should have, जब भी RV enlarged हो or active हो, always rule out the AST. So assessing right-sided valves for the regurgitation, whenever there is dilated RV and it's active, always go for assessment of the pulmonary valve as well as for the tricuspid regurgitation. Estimating the pulmonary pressures is last but not the least. We all know how to measure it, but there are a few things which I would like to stress upon, that your Doppler alignment should be good. You should have a good, envelope, then we should measure it. And, by adding this right atrial pressure, we can have a pulmonary artery systolic pressure or the right ventricular systolic pressure if there is nothing wrong with the pulmonary valve or the pulmonary vasculature. So we all know how to do it. So this is the subcostal view, and this is the IVC. And here we need to remember two things. This 21 figure, I don't know how to place this, marker, but anyway, we need to remember the magic number of 21 and 50%. Less than 50%, more than 50%. In all the board exams, this is going to help you. This table is going to help you. So by adding this with the TR jet velocity pressure, we can have the PA pressures. So which RV functional parameters are reliable after cardiac surgery? So TEP-C and RV free wall S prime are reduced after pericardial opening and return to normal after 6 to 12 months. There is a study where they found that after 3 minutes, the TEP-C came down. After pericardial, 3 minutes after pericardiotomy, they found out that this TEP-C was less. The RV global longitudinal strain reduces after pericardiotomy, but the reliable features which we can measure in the perioperative period are the RV fractional area change, RV 3D EF, and this TI index. So I will conclude by saying the right ventricular function in the perioperative period is as important to assess as left ventricular assessment is. Comprehensive right heart assessment should include quantification of RV and RA dimensions, RV systolic and diastolic function, pulmonary and tricuspid valve morphology and function, and estimation of pulmonary artery pressures. Thank you very much.
I think there was a time when we cardiologists used to go to the ITC and evaluate these patients, but now our cardiac kinesists are doing the job. I think once you're assessing a patient after the bypass or an operation, then you have a privilege to have a look at the previous report. Most of these patients have got echoes which were done pre-operatively, and whether RV size was normal or it was abnormal, and was there any hypokinesis or hyperkinesis. So you have an advantage. So if you find an RV is probably there is inferior MI with RV infarct, or you can have a pulmonary embolism, which can affect the RV indices. These are the problems. Then one thing you did not mention was RV tamponade, which can occur after operation, because at times we have seen there are regional tamponade, there is external compression of the RV, which can be ultimately the source of hypotension and then low urine outputs, and then, that is indication of reopening. And so, and then we have at times, very rarely you can leave something in the pericardial space like towels, which can affect RV function. So one should not remember to have a holistic approach of looking at the RV post-operatively.
Sir, thank you very much. It's a very valuable comment, and definitely we have that RV tamponade, and it's really missed. Yes.
Nice presentation, Dr. Fakher. Some comments that this
you see
RV should be assessed in a dedicated RV directed view. This is very important. Never in a RV four-chamber view.
Modified.
Professor Robert Lange, who is the lead author in all the recommendations of cardiac chambers, I met him at Philippines, and he specifically mentioned that this is the basic mistake. Secondly, people usually ask why we do mid RV dimension. When RV base we have measured, RV length we have measured, it's enough. No, RV enlarges in its mid. So that is very important, which is usually missed. And thirdly, you haven't mentioned the epicardial fat thickness. That affects RV function, and it is an important parameter now for the assessment of HF-PEF. Last, IVC, I think this is an older slide, about 2001. IVC measurement, because of its irregularity, has been taken off, and now you have to mention TR velocity instead of adding RA pressure to it. That is, I think I've just read about 2 or 3 months back a paper.
इसका सिर्फ एक जवाब सर, जो ये IVC की जो हमने ये लिया हुआ है, ये दिस इज फ्रॉम अ लेटेस्ट बुक on 2024, and I've got that book. I can share that with you. This is a table actually photographed from that place, and उसके ऊपर number भी लिखा हुआ है उसका, and this book was published in 2024. This last year.
I thought that the numbers which Fakher showed were simple and easy to accept. The other thing is that after hearing Brigadier Fakher, we can say we have always been thinking now that the right ventricle is no more the forgotten right ventricle. That is very important. The other thing is that why do we have the right ventricular strain which becomes different, or you cannot interpret it after pericardiectomy? The reason for that is because now the heart is actually moving as a pendulum and not contracting the way it was contracting when it was enveloped in the pericardium. So that difference actually makes the right ventricular strain different. And I'm sure that he must have seen it while the operations are being carried out also. If there are any more questions.
Excuse me, जब भी सर्जरी में प्री ऑप केसेस में हम देखते हैं कि अगर बर्नड आउट एलवी है और उसके साथ आरवी है, तो मैं अपने सर्जन को यही कहता हूँ कि सर ये करने वाला केस नहीं है, ये मरने वाला केस है, तो इसलिए इसको ना करें तो बेहतर है.
I think absolutely right, क्योंकि right ventricular function is extremely important for the left ventricular function.
Dr. Fakher, if a patient have the anatomical right ventricle which function as a systemic ventricle, so would you apply the same parameter, or they are the different one?
Ma'am, I don't have any experience of having the right one, because I don't do the pediatric anymore. But if any pediatric cardiologist is here, so he will be the right person to answer that. I'm doing the adult, and we are not doing adult congenital heart disease on this side, and the pediatric cardiac surgery side is doing it. I'm really sorry. Is there anyone else who can answer this question? But I don't know the answer really.
She asked me yesterday, and I told her that this is not the anatomy we are seeing. This is the physiology we are seeing. So if the RV is functioning as LV, we will take it as LV, physiological LV. No, we are not taking the thickness in account. We are taking the E velocity and A velocity and all these things. So Tipu can comment on that.
I think this is an interesting question, but probably logically it appears it would be different if it's the functional left ventricle and not the right ventricle.
Assalamu alaikum, sir. My question is regarding post-cardiac surgery patients. Sir, the difficult situation that you saw, that when we see it in ICUs, we are doomed, sir. I request your comments on that, that how we can assess that difficult hearts. And sir, since you are an intensivist, so how can we rescue ourselves in that situation particularly, sir?
Oh, it's a very good question. Definitely, Echo is going to help you, because that's the only tool which you can use in the perioperative period when the chest is open. Yesterday or day before yesterday, someone was asking why did you not do the chest auscultation. So I said, آپ نہیں کر سکتے, chest open ہے. So Echo, لیکن آپ transesophageal echo کر سکتے ہیں, ٹھیک ہے. اور ٹرانسفیجل ایکو اور ٹرانسسیک ایکو ہی آپ کو اس پہ سارے فنکشن کے بارے میں بتائے گی, چاہے جیسے سر نے ٹیمپوناٹ کا ذکر کیا اس کے بارے میں. یس, مینجمنٹ جو ہے اسٹارٹس, اگر آپ نے پیری آپریٹو پیریڈ میں جیسے ہی آپ آف آئیں, یو ہیو جسٹ کم آف فرام دا بائی پاس, سو ایڈریس دا پرابلم دین اینڈ دیئر. سو دیٹ از دا رائٹ ٹائم ٹو ایڈریس اٹ. whether you want to revise or you have to revise your craft, do it. Whether you have to go again on bypass, replace your valve again, or repair, if you have done repair, revise your repair. Address the issue then and there. Afterwards, آپ ریسکیو کر سکتے ہیں میڈیسن کے ساتھ, ٹھیک ہے, دیٹ مے اور مے ناٹ بی سکسیزفل, ٹھیک ہے. اس میں بہت ساری چیزوں کا رول ہے, ڈبیٹامین, میلینون, there are lot many pharmacologies involved. But the definitive treatment is جو آپ تھیٹر میں کر سکتے ہیں, وہ آپ ادھر سے کر کے نکالیں پیشنٹ کو, ٹھیک ہے. میں پیری آپریٹو اس میں بارے میں
کرنا اسی وقت چاہیے.
اسی وقت سے.
السلام علیکم سر. سر, as you mentioned you start کہ pulmonary valve is the most neglected valve in reporting and
actually
echocardiography.
this thing is missing basically.
Missing. I just want to ask sir, is there any association of RV-PA coupling and uncoupling in mentioning the RV function, as you mentioned that TAPC and RVS TDI, if they are still normal, but RV-PA coupling and uncoupling comes out to be the stage 1, stage 2, stage 3 and stage 4 RV dysfunction, which is actually very important in the mortality of the patient, regardless of the fact that TAPC is equally normal hogi, shayad wo 20 ho, but a patient comes out to be pulmonary artery pressure of 80, and if you divide a 20 over 80, it will comes out to be less than 0.36, and if you have a significant TR, it lies in the stage 4 RV dysfunction. So rather we are mentioning it a normal RV function, or it's an RV-PA uncoupling stage 4 RV dysfunction. میرا یہ سوال ہے سر.
اچھا دیکھیں, جب بھی ہم آر وی کا فنکشن جو ہے وہ وین یو ایکسپلین اور رائٹ ڈاؤن آر وی کا فنکشن, اس میں بہت ساری چیزیں اس میں انکلیوڈ کرتے ہیں, ٹھیک ہے. اگر کوئی ایک ہارٹ از کریٹنگ اے پریشر آف 80 ملی میٹر آف مرکری, دیٹس ناٹ گوئنگ ٹو بی دیٹ بیڈ ہارٹ, ٹھیک ہے. وہ آر وی اتنا برا نہیں ہوگا, ٹھیک ہے. ہمارے اس میں ہم اس کے لیے سرجری میں پہلے بھی ایک دفعہ اس میں کہا تھا کہ سرجن کو ہم کہتے ہیں کہ سر یہ آر وی اتنا برا نہیں جس کا 80 ملی میٹر مرکری جو ہے اس کا ٹی آر کا گریڈینٹ آ رہا ہے, ٹھیک ہے. تو اس کو اور ہم سرجری کے لیے چلے جاتے ہیں, ٹھیک ہے. تو باقی یہ ہے کہ اس کے اوپر ہم بہت زیادہ ڈیبیٹ کر سکتے ہیں بہت ساری چیزوں کے اوپر, ٹھیک ہے. کچھ چیزیں
آر وی پی اے کپلنگ جو پوائنٹ ذیشان نے کہا ہے, دس از اے ویری امپورٹنٹ پیرامیٹر, اے ویری سٹل ون. یو کین ٹیک اٹ ایز ہی از سیئنگ ایز اے سروگیٹ مارکر فار آر وی, بٹ وی ہیو ٹو اسٹڈی اسپیشلی ان سچ کائنڈ آف سچویشنز where things look apparently normal, RVPA becomes uncoupled, and that is very important. We must look for that.
Sir,
most of cases.
Sir. Yes.
Sir, my simple question: what is the role of RV function in non-cardiac surgery? کیونکہ جتنے جنرل ہاسپٹلز ہیں وہاں لوگ صرف ایل وی فنکشن تو مانگتے ہیں, لیکن آر وی فنکشن کوئی نہیں مانگتا. از the role of RV function in non-cardiac surgery?
سر یہ تو یوزلی چونکہ ہم لوگ صرف کارڈیک سرجری کے ساتھ ہی ڈیل کر رہے ہیں, اس سوال کو تو میں سر ٹیپو یا سر شہباز کی طرف ریفر کر دوں گا. لیکن میرے خیال میں سر آر وی کا جو جتنی گائیڈ لائنس ہیں آپ کا سوال بڑا اچھا ہے. لیکن سر جتنی گائیڈ لائنس ہیں وہ یہ کہتی ہیں کہ جی جو ہے جہاں آپ ایل وی کا فنکشن وہ کریں وہاں آپ آر وی کا وہ بھی ضرور کریں. اور جتنی گائیڈ لائنس وہ یہ کہتی ہے کہ آپ آر وی کا ایک ڈائمیٹر چاہے میئر کریں آپ ضرور اس کے اندر لکھیں. ٹھیک ہے سر. جتنی گائیڈ لائنس وہ یہ کہتی ہیں کہ آپ ٹرائیکسپیڈ ویلو کا اینالس ضرور مینشن کریں اس کے اندر. آپ اپنی جو ایکو کی رپورٹ ہے چاہے وہ بی ایس سی کی گائیڈ لائنس ہیں چاہے آپ امریکن سوسائٹی آف ایکو کسی کو بھی آپ وہ کر لیں یہ سی وی آئی کی, وہ آپ کو ایک منیمم ڈیٹا سیٹ ضرور بتاتے ہیں. تو سر آر وی فنکشن تو سب میں انکلوڈیڈ ہے میرے خیال میں. اٹ شوڈ بی پارٹ اینڈ پارسل آف دی یو نو کمپریہنسو رپورٹ اکارڈنگ ٹو اینی گائیڈ لائنز اکراس.
بالکل میرا خیال ہے کہ یہ کمپریہنسو رپورٹ کا حصہ ہے. اینڈ یو ایکچولی مینشن دا رائٹ سائڈڈ ہارٹ کہ اس کا فنکشن کیسا ہے, اس کے چیمبر سائزز کیسے ہیں. تو یو ول ایکچولی ڈو دیٹ.
اس میں ایک چیز اور جو ہم وہ کریں کہ 1/3 آف the inferior wall MI they have got a RV infarction as well. So اگر ہم نہیں کریں گے اس کے ساتھ اگر اسکیمک ہارٹ ڈیزیز میں بھی اگر ہم دیکھ رہے ہیں تو سر ہم 1/3 تو ہم RV انفارکٹ بھی مس کر جائیں گے نا کہ جی RV جو ہے کے بارے میں اگر ہم نہیں وہ کر رہے. اور مینجمنٹ جو ہے اس میں ڈفرینس ہو جاتا ہے کہ اگر ساتھ میں RV کا انفارکٹ بھی ہے. ٹھیک ہے. جو انٹینسو کیئر مینجمنٹ ہے یا جو پوسٹ آف کیئر مینجمنٹ ہے اس میں آر وی کے انفارکٹ کے ساتھ آپ کی مینجمنٹ ڈفرینٹ ہو جاتی ہے. تو کرنا تو سب میں چاہیے لیکن یہ ہے کہ کچھ چیزوں میں مینجمنٹ میں بھی فرق پڑ جائے گا اگر ہم نے نہیں وہ کیا ہوا. اب میں آپ کو بتاؤں سر مرٹیلٹی اور موبلٹی میں بہت زیادہ فرق ہے. اگر آپ نے ایل وی کے اوپر صرف کمنٹ کیا ہوا ہے اور آر وی کے اوپر نہیں کیا. سر بلیو یو می کہ دیر واز اے ٹائم کہ ہمارے پاس آتے تھے جی مائٹل بھی ریپلیس کر دو, ایورٹک بھی ریپلیس کر دو, ٹرائیکسپیڈ بھی ریپلیس کر دو. ٹھیک ہے سر. اور سرجن جو ہے سر وہ بڑی اچھی پلمبنگ کر کے ہمارے حوالے کر دیتا تھا اور پیشنٹ جو ہے نا سر شام کو اس کی ڈیتھ ہو جاتی تھی. ٹھیک ہے. اینڈ وی ور لائک کیا ویئر از دا پرابلم. اور سرجن میں نے اتنی اچھی سرجری کی ہے 3 ویلو اتنے اچھے لگائے ہیں اور تم لوگوں سے پوسٹ آپریٹیو مریض میں نہیں سنبھالا جاتا. اور جب ان کو ریٹروسپیکٹیولی ہم نے دیکھنا شروع کیا سر بعد میں ان میں تو سب میں برنٹ آؤٹ آر وی ہوتا تھا اور آر وی جو ہے بالکل ہل ہی نہیں رہا ہوتا تھا. ٹھیک ہے. اور آر وی کو چونکہ کمنٹ ہی نہیں کسی نے کیا ہوتا تھا اس کے اوپر تو سرجن تو صرف کہتے یار اتنا اچھا ایل وی ہے دیکھو مائٹر اسٹینوسس ہے اتنا اچھا ایل وی تھا پریزروڈ ایل وی لکھا ہوتا تم سے پریزروڈ ایل وی بھی نہیں سنبھالے جاتے. سر آر وی از ایز امپورٹنٹ ایز لیفٹ وینٹریکل از. ٹھیک ہے. اور برنٹ آؤٹ آر وی جو ہے وہ پھر ہارٹ ٹرانسپلانٹ والا پیشنٹ ہے وہ آپ اس کے جتنے مرضی ویل ریپلیس کرتے ہیں جتنی مرضی اچھی پلمبنگ کر لیں اٹس ناٹ گنا ریکور. سر میرا خیال ہے میں ہی آپ اور سب کے ٹی بریک کے درمیان میں ہوں. جتنے سوال پوچھیں گے ٹی بریک لیٹ ہوتی جائے گی. ٹھیک ہے.
فخر آپ ٹی بریک کے نہیں سیکنڈ سیشن کے درمیان میں ہے بیکاز وی آر گوئنگ ٹو اسکویز دا ٹی بریک. ویل گیٹ دا ٹی اینڈ کم بیک اینڈ ویل اسٹارٹ دا سیکنڈ سیشن آن ٹائم. The reason being we have international commitments
Sir,
which we are going to honor.
So I hope you are not skipping the tea break.
Just one comment.
Yes.
I think we had an excellent session. This was an excellently organized conference. The issue is attendance. I think the attendance is not as much as we should expect. So hall is only 1/3, filled. Reason, I think we have not done enough marketing for this. Echo is very important, is very popular. I think for next year onward, we should start 6 months earlier, give the dates and reach to the GPs also. And the people who are doing, echoes in the community, general community.
Sir, totally agreed.
Let me complete, sir. So marketing and then reach to people so that we can increase the attendance and increase the level of, skill in the echocardiography.
Sir.
Then I have another proposal that instead of, having an echo meeting, we should call this meeting of cardiology imaging.
Yes.
We already have CT, we have MRI in this, we have nuclear. So this should be converted into a society of cardiac imaging or something like that. And then lastly, I think I cannot see anybody from the Department of Cardiology, FIC, except perhaps Azhar and Bariz Zohur. I think Department of Cardiology should take more interest in echocardiography.
Farhan, we have already started talking about it as the cardiovascular imaging.
یہ چیز جو ہے نا وی ہیو آلریڈی ڈسکس دس پوائنٹ یسٹرڈے کہ اٹس ایکچولی جو ہے نا کارڈیو ویسکولر امیجنگ، بٹ تھوڑے سے لیگل ایشوز ہیں سوسائٹی کا نام چینج کرنے میں، اس لیے چینج نہیں کیا، بٹ اوور آل اٹس بیسیکلی دا کارڈیک امیجنگ. جہاں تک جی پیز کا سوال ہے، آئی ڈاؤٹ کہ دس از فروٹفل فار جی پیز، بٹ آئی اگری کہ جو ہے نا ہمیں
ڈپ کارڈ کارڈیولوجسٹ
آئی اگری
آئی
آئی اگری کہ جو ہے نا جو جونیئر کارڈیولوجسٹ ہیں ان سب میں مارکیٹنگ کو بہتر کرنے کی ضرورت ہے. بٹ ایک تھوڑا سا کنٹروورشیل پوائنٹ میں ضرور یہاں کہنا چاہوں گا، وہ یہ کہ اگر یہی کانفرنس کراچی میں ہو رہی ہوتی نا تو بلیو می یہ پورا بھرا ہوا ہوتا. تو مجھے نہیں پتا یہاں کیوں نہیں آئے لوگ.
I think
marketing. Use the social media.
thank
Get to
you
people. Make a WhatsApp
thank
group.
you very much.
ہمارا ECG کی میٹنگ ہوتی ہے، حال 2 دفعہ بھرا ہوتا ہے.
Sir, I want to ask the role of RV function in giving the cardiac fitness pre-operatively for non-cardiac surgeries. اگر میز ہے یا آر سی آر آئی اسکور ہے اس میں تو آر وی فنکشن نہیں ہے.
کس کے اندر؟
جیسے آر سی آر آئی اسکور ہے یا میز ہے، اس میں تو آر وی فنکشن نہیں ہے. پر واٹس دا رول آف آر وی فنکشن؟
ایس ٹی ایس اسکورنگ میں بھی نہیں ہے، اور اپنا ایک دو اور اسکورنگس ہیں ان کے اندر بھی نہیں ہے. ہاں ایگزیکٹلی، آپ بالکل ٹھیک کہہ رہے ہیں، لیکن اگین جہاں تک انیستھیزیا یا سرجری از کنسرنڈ، آر وی فنکشن از ایز امپورٹنٹ ایز ان کارڈک سرجری. ٹھیک ہے، وہاں پر بھی آپ کو بہت زیادہ کیئرفل ہونا پڑتا ہے. اینڈ دین یو سے کہ اوکے آپ کو رسک اسٹریٹیفکیشن کرنی ہے. ٹھیک ہے، اگر ایمرجنسی سرجری ہے یو گو فار اٹ، بٹ یو شیئر دا رسک ود دا فیملی اینڈ ٹیل دیم دیر مے بی اے ٹیبل ڈیتھ. ٹھیک ہے، اور میں آپ کو بتاؤں کہ وہ اب دور گزر گیا جب لوگ کہتے تھے جی کہ یہ جی اے کے لیے فٹ نہیں ہے. نو ون از انفٹ، نو ون از انفٹ فار دا جی اے، بٹ دیر از رسک اسٹریٹیفکیشن. ٹھیک ہے، اینڈ رسک ایکسیپٹنس بائی دا فیملی. ٹھیک ہے، سو یہ آپ کی بات بالکل ٹھیک ہے، بٹ دیر از ڈیفینیٹلی انکریز رسک ود آر وی امپیئرمنٹ.